Thank you so much. I'm Kelsey Largent. I'm a psychologist, and I work with individuals with chronic health conditions. So today I'm going to talk a little bit about addressing educational, cognitive, and social needs in individuals with NF type 1. So NF type 1 has a significant impact on emotional, social, and cognitive abilities. For example, patients with NF type 1 have difficulties with social relationships at times as a result of the disease and are 4 times more likely to receive a diagnosis of autism than the general population. In addition, patients with NF report increased symptoms of depression and anxiety in compared to the general population. But for today's talk, I'm actually going to focus in on how NF type 1 affects the brain and how the brain processes information, better known as cognitive functioning. So my objectives for today are to describe common challenges in cognitive functioning in patients with NF type 1, to provide information on how to learn if you or your child meets criteria for one or more of these problems, to discuss supports in the school that can address these challenges, and then to provide additional resources and tips that you can use on your own to overcome challenges. I thought I would start off with a little brain humor to lighten the mood. I know that sitting through presentations can be a little bit tiring, but hopefully you had your caffeine this morning. I'm just going to try to hit the highlights today because I know we're running a little bit behind, but feel free to grab me later and ask me any questions. So what do I mean when I say that someone has a deficit in cognitive functioning? In order to answer that question, I think it's helpful to look at something called the normal curve. So the normal curve is a distribution that measures how the entire population falls on different skills and abilities. So we have a lot of different things that we're really good at and then some things that we're not as good at. And the normal curve helps us look at those abilities compared to people that are similar to us. So for example, if you were rating me on knowledge about psychology, I'm probably going to fall on the higher end of the curve because I'm a psychologist. But if you're rating me on basketball skills, I'm going to fall on the lower end of the curve because I'm not very good at basketball. And it's the same thing with cognitive functioning. Most people fall somewhere in the middle of the curve, but there's some people that fall on the higher end and some people fall on the lower end. And there are a lot of different skills and abilities in terms of cognitive abilities that help us understand a person's strengths and weaknesses. So you might be someone who has verbal skills that fall on the average range, but maybe your visual spatial skills fall on the lower end of the curve. So the reason this is important is because patients with NF type 1 are more likely to have difficulties in cognitive functioning due to the disease. And that's because neurofibromatosis is involved in brain development, which results in patients with NF type 1 being at an increased likelihood to demonstrate lower scores on intelligence tests and be more likely to have a learning disability. Some of the most common problems in cognitive functioning that are seen in patients with NF type 1 are things like language skills, visual spatial skills, so your ability to solve problems involving spatial relationships, motor skills, things like tying your shoe or riding your bike, executive functioning, memory, and attention. In fact, studies show that up to 40% of patients with NF type 1 have a diagnosis of ADHD. So you might be wondering what executive functioning is because it's a term that mostly psychologists use, but it's a really important skill that we use to do things all throughout our day. So for example, you need executive functioning skills to plan the tasks that you're going to do, to gather the materials that you need, and even decide how much time it's going to take you to complete that task. You also need executive functioning to start the activity and monitor yourself during that activity to make sure that you're on task. Executive functioning is also really important for things like emotional control and flexibility when things aren't going your way. So because of that, you might see some behavioral difficulties in individuals that have executive functioning problems. So for example, people that have executive functioning problems might have trouble thinking before they act, might have trouble following the rules. They might get frustrated a little bit more easily than others. They might be a little bit more disorganized and have poor time management skills. So what should you do if you suspect that your child might have some learning problems? The first thing I would like you to do is actually talk to your child directly about these problems. Often we really underestimate how much kids understand about what's going on with them, or we feel like pointing it out is going to upset them. But by having a conversation with your child, we can talk about the things that we can do to address these problems, and typically children feel better once we kind of point out what's going on. The next thing to do is to talk to your child's teacher and ask them questions about what they notice about your child in the classroom setting. So often teachers are going to have really valuable insights about some ideas that can be helpful, that can be implemented right away in the classroom setting. Sometimes, however, the teacher strategies aren't enough to address problems, and testing is necessary to better understand what your child's cognitive strengths and weaknesses are. And there are two main choices when it comes to testing done by a school psychologist and neuropsychological testing. So school psychologists typically do testing that's more focused, and their aim is really to understand what kind of special education services that your child needs in school. Neuropsych testing is a little bit more comprehensive, and it gives people recommendations about things that can be helpful in school, but also can give you recommendations for strategies that you can implement outside the school setting. So I'm going to talk a little bit more about neuropsych testing. So neuropsych testing is a specialized comprehensive evaluation that's done by a neuropsychologist that provides information on how the brain is affecting behavior and learning. So the results provide information on a person's strengths and weaknesses across a very wide range of cognitive skills. And it can help your child's school determine, again, what kind of special education services that they may need in the classroom, but also some recommendations for how to overcome challenges outside of school. So what to expect when you come for a neuropsych evaluation. Typically, it's a very long day, so up to 8 hours of testing. The neuropsychologist is probably going to ask you a lot of questions about your child's background to get a detailed history of what's been going on in terms of their learning and development. And then the neuropsychologist is going to meet one-on-one with your child to do direct testing while you fill out some questionnaires about how your child is functioning at home. And then typically that neuropsychologist is also going to ask your teacher to fill out some questionnaires to understand how they're doing in the classroom setting. And then it's important to know that you're not going to get the results that day. Typically what happens is you'll be sent home, and the neuropsychologist will score everything and write up a report, and then invite you back for a feedback session where they're going to go over in detail what kinds of things they found, and then be able to talk about some of their recommendations that can be helpful. So you may decide, though, that your primary concern is to obtain special education services or accommodations for your child in the classroom setting. In that case, you would want to request testing in school. So to do that, you would request an evaluation in writing that talks about what concerns you have about your child in the classroom setting, and then also would include information about your child's diagnosis. And then in the state of New York, they have schools have 45 days to respond to the request and then initiate testing. And then after all the testing comes back, they're going to sit down with you and talk about recommendations for what supports that your child might need in school. So there are two main plans that provide support to children in school: the 504 plan and the individualized education plan. So a 504 plan refers to Section 504 of the Rehabilitation Act of 1973, and it prohibits exclusions of persons with disabilities from federally funded programs. So basically, it's going to provide modifications or accommodations for your child in the classroom so that they can have an equal opportunity to perform to their potential. An IEP is a little bit different. It's based on the Individuals with Disabilities Education Act, or IDEA, and along with accommodations in the classroom, it's also going to provide special education instruction. So in order to qualify for an IEP, the student has to have one of these diagnoses. And so for children with NF, they're going to qualify just based on their medical diagnosis, but typically a school is going to want some evidence that their diagnosis is impacting their academic performance, and is going to want to do some testing to understand that. Otherwise, they would typically implement a 504 plan. So I'm going to shift gears a little bit for the adolescents and young adults in the room who finished formal schooling, and you're maybe wondering how some of these cognitive differences affect your life moving forward. So cognitive functioning isn't just important for going to school, it impacts how you function in a lot of different areas, and it's really important for becoming a successful adult. So, for example, you need your cognitive functioning skills in the health arena to make doctor's appointments and to ask questions about your health at the doctor's appointment. If you're interested in pursuing higher education or vocational school, you might need your cognitive functioning skills to get into the program, to advocate for yourself while you're in the program, and to take the steps that you need to graduate. If you decide you want to get a job to support yourself, you'll need cognitive functioning to find a job and manage the money that you earn. And you also need your cognitive functioning skills to maintain relationships with friends and family and make new relationships. So I wanted to just briefly go over some tips to improve executive functioning skills, because I think this is an area that can be really helpful for both children and young adults, and it's something that is very helpful in order to achieve the goals that you're going to set for yourself if you're a young adult. So for example, if you have trouble with executive functioning, very large tasks are going to be really overwhelming. So it's really helpful to break down a large task into smaller steps. So for example, if you're cleaning your room, you might break it down into making your bed, picking up things off of the floor, and then maybe even putting away your clothes, for example. You might set a timer for 15 minutes. This is one of my favorite tips, so that, you know, maybe working for 30 minutes or an hour is really overwhelming for you, but you can kind of tackle one thing at a time in a 15-minute chunk. It can also be helpful to create a checklist of the things that you need to get done, which you can do for regular routines like getting ready for school or work, or you can make a checklist for more longer-term goals like applying to college. It can also be really helpful to organize your space so that you don't waste cognitive energy finding the things that you need. So you might decide to keep things in the same place that you need every day, or use labeled bins or hooks in your apartment or home in order to find the things that you need. Okay, so I was going to just end the presentation with some resources that can be helpful if you or your child is experiencing learning difficulties. So the National Center for Learning Difficulties and the New York Office of Special Education have a lot of great resources that go over some of the information that I touched on today, especially about 504 plans and IEPs. And then finally, the Friends of Quinn is specifically geared toward young adults with learning difficulties and can be a great resource if you're somebody who is a little bit older and wants some resources that can be helpful in navigating some of these issues that I talked about. That's it.
Great. Well, thank you all for having me back here again this year. I had the opportunity for the first time to speak at this conference last year, and it was really a great privilege. And over the course of the year, I've had the opportunity to meet many of you guys, many of your families, and really one of the highlights of my days are working with our kids with NF1. They may not like it because of the eye drops, but I personally do love all of our interactions, and so thank you as well. This talk will be a little bit of a repeat of what I talked about last year, and that's good. The more times we hear something, the more we learn, but also with some different twists. And with that, begin. And actually, if it is possible, I think with the lights dimmer is probably better for this talk. You guys don't need to see me. The pictures are more interesting. So again, why is a pediatric ophthalmologist here? First, because we can help make the diagnosis of NF1, and you guys are all mostly familiar with the clinical criteria to make the diagnosis of NF1, and several important ones of them can be diagnosed in the eye. And so that's one of the things I do. The second point is kids really don't know or can't communicate any vision problems they're having. And so when you have a condition that can cause profound issues in vision, you kind of have to have a screening regimen in place to find those issues before they become a big problem. And so screening eye exams in NF1 are absolutely critical. And the main reason, or one of multiple reasons, is to look for things called optic pathway gliomas. And we'll talk a little bit more about that, but no longer do we do routine screening MRI scans for these optic pathway gliomas. And so it's important that we find subtle clues that maybe things are going on with the vision in order to appropriately recommend further workup. And lastly, just a plug for pediatric ophthalmologists in general. Not all eye doctors, and there's a whole spectrum of eye doctors, optometrists, and even adult ophthalmologists have the tools to be able to adequately examine kids' eyes. And so it's important that you work with someone who feels comfortable working with kids and checking their eyes, and that's usually a pediatric ophthalmologist. This slide is probably the most important slide, and this is kind of how I approach the care to all of our families here. And the goals of my exams are, number one, if we're going through the diagnosis, to help make that clinical diagnosis, and number two, if we have a diagnosis, is to screen for subtle or sometimes not so subtle signs of changes in vision to prevent blindness. And so what we'll normally do is we'll do initial screening. If everything looks pretty good, the first year we'll follow every 6 months. After that, really depending on how the child is doing and what suspicion, we'll be seeing each other every 6 months to a year up until about age 8. And then after that, we can generally spread out the visits a little bit longer. And again, if there are any signs of concern, that will usually trigger a discussion with your NF1 doctor about doing a further workup, usually requiring an MRI. And if that MRI is positive, discussions about treatment, and if it's negative, close follow-up. So the first kind of group of families that I see are patients. Usually they have suspicion of NF1 because they have these café au lait spots, café au lait macules, and then they're sent to come in and see an eye doctor, sometimes even before they establish care with an NF1 provider. And so the question is, why? Why are they seeing me? And again, these are the old or current, a simplified list of the current criteria, and several of these can be diagnosed from an eye exam. Most commonly, what we've been looking for are these things called Lish nodules. So Lish nodules are little bumps. They're called iris hamartomas. So little bumps on the iris or colored part of the eyes. Generally, when an iris is dark, they're often lighter color. When an iris is light, they're often darker color. They're small, so they're microscopic, and so we use a special equipment called a slit lamp in order to look for them. And having 2 or more of these is one of the clinical criteria for making a diagnosis of NF1. Now, just a note about Lish nodules, because a lot of times when I see families undergoing this workup and this evaluation, there's a lot of apprehension about whether I saw Lish nodules or not. Number one is they don't affect vision. Now, even though they are part of the spectrum that is NF1, usually they're not visible to the naked eye, and they don't affect vision. So just the presence of them should not be a point of an alarm in any family who has a child with NF1. The absence of Lisch nodules does not rule out having NF1. So again, it's one of the clinical criteria that we have. And even throughout childhood, between ages 5 and 10, only about 50% of kids actually have these Lisch nodules. And so again, it's something that may develop over time. And so on our first visit, if we don't see it, it doesn't mean that your child won't develop them later on. But again, they don't affect vision. That brings us to kind of talking about updating the guidelines, the clinical guidelines for NF1. And so this is a really important slide. And so if you look at those bottom pictures down there, these are photographs of the back of a child's eye, and you can trust me that they look normal, and you don't see anything abnormal. But when we do a special infrared scan of the back of the eye up here, you can see all these little white spots. And these are actually what are called choroidal nodules. And the choroid is a space in the back wall of the eye. Again, kids with NF1 get these characteristic nodules there that we can see on these infrared images. These, like Lisch nodules, they don't actually have any impact on vision, so they're just there. But some studies have shown that in younger kids and kids in general, they may actually have a higher prevalence in NF1 than even the Lisch nodules. And so as this technology to look for these becomes a little bit more routine, these are things that we can look for also. Again, it does require taking a picture of the back of the eye, so it may not be relevant to infants, but to other smaller children. It's something that we can capture. Okay, so then we have families, many of your families here, where you have a diagnosis of NF1, and the question is, do we need an MRI scan? And so from an ophthalmologist standpoint, there are a couple of different reasons why we recommend getting an MRI. First is to look for abnormalities, look for pathology. And generally what we're talking about are these optic pathway gliomas, but it can be other aspects of NF1 that you get around the eye. So you can get these plexiform neurofibromas in the orbit or the eye socket, in the eyelid, or you can see changes in the bones around the orbit as well. Importantly for me is for looking for, as part of a workup for unexplained changes in vision. And the key word here is unexplained, because as I'll talk about in a minute, there are lots of reasons why kids will have changes in their vision. And if I can't explain it in the most common ways, that would be a trigger to do a further evaluation. Also, if there's signs of increased pressure around the brain, which we can see in the eye from changes in the optic nerve, whether swelling or paleness of the nerve, or other changes in neurologic symptoms that your other providers may pick up as well. So here's a diagram of the eye, and when we're talking about optic pathway gliomas, what we're talking about are some of the cells in the nerve, the optic nerve that connects the eyeball to the brain. And like I like to tell all families, we see with our brain, not with our eyes. Our eyes are just an organ to send signals to the brain to be interpreted. And so any changes in that cable that connects the eyeball to the brain can impact vision. And that's how these optic pathway gliomas can impact vision. Sometimes it's pretty obvious. So this is an example of an 8-year-old child who came in with severe vision loss in his right eye. And again, these are photographs of the back wall of the eye, and you can see this is the optic nerve right here as it looks when we look into the eye. And this nerve right here is a lot more pale or a lot more white than this nerve here. And this is the left eye, and this is the right eye. And lo and behold, when this patient had an MRI, he had a large optic pathway glioma of his right optic nerve. Now, I'm not an expert in reading MRIs, neither are most of you, but we can put some color on it. So you can see the different sizes of the sizes of the nerve suggestive of an optic pathway glioma. Sometimes it's not as obvious, and it's a little bit tricky. So this is a 2-year-old who actually has pretty normal visual function. And when we look in the back of the eyes, I can also tell you guys that these are pretty normal looking pictures of the back of this child's eyes. And for other reasons, actually, this child ended up getting an MRI. And there was concern for an optic pathway glioma in the left eye of this child. And so then we have some tricky questions. So the visual function is pretty good. What does this mean? What does this mean in terms of how the child is doing, how it's affecting the child's vision, and how do we monitor kids like this? So the number one thing we do is we have to check vision, and this has to be done in an age-appropriate way. So for some kids, they can read the full eye chart. Some kids, we can use this limited set of letters to check vision. Sometimes we use pictures to check vision. Sometimes we can even use these special cards. These are called teller acuity cards, where one side of the card has some striped lines and the other side is blank. And if you hold them up in front of a child, they'll look at the side with the stripes if they can see it, because it's more exciting. And these are all different ways when we can actually measure vision in really young kids. The other things we can do, we check for changes in the pupil function in the child, and we check for changes in their peripheral vision, because changes in the optic nerve or in this visual pathway can affect their peripheral vision. In older kids, we can do this through these things called automated visual field tests, it's actually a pretty challenging test, but if a child can do it, it can actually map out areas where the child's having difficulty seeing. Another technology that we're using more frequently are called OCT, or ocular coherence tomography, where we can actually use a special camera that takes these really incredible pictures of the back of the eyes and actually can measure the thickness and the health of the nerve tissue that's going into the optic nerve. And so, for example, in the child that I was talking about before, this is a picture of their OCT scan of the nerves, and there is maybe some concern for some thinning in that left eye as well. And so this is a type of child where working with the NF1 team here, we'll make sure that the MRI scans are not changing, make sure the visual function's not changing, make sure the OCT scans are not changing. You put all this information together in order to understand how this optic pathway glioma is affecting vision. It's not easy, especially in younger kids. The last thing I just want to briefly mention is a question that for me is really a key question. And so if we do have a change in vision, is that always explained by NF1, or could it be something else? And I have to put a quick mention for a condition we call amblyopia. So the amblyopia, for all the kids I see, that's the number one condition I'm looking for. And what does that mean? Well, it means that during childhood, our brain is actually learning how to see. So we're not born seeing 20/20, and anything that interrupts that development of vision is called amblyopia. And so the connections between the eyeball and the brain aren't as strong. This can be caused by differences in prescription between the two eyes. So if you think about it, if one eye has a strong prescription and one eye has a weak prescription, the brain is going to prefer to use the eye with a weak prescription. It can be because of strabismus or crossed eyes. So if one eye is straight and one eye is crossed, the brain's going to prefer to make connections with the eye that's straight. Or it can be from anything that blocks the eye from seeing, whether it be a droopy eyelid, a cataract, or anything else. And so any of these types of examples can impact on visual development and cause amblyopia. And we treat this in various different ways with glasses, with what we call penalization treatments, with patching or blurring eye drops. Sometimes you even have to do surgery. But the key is that you need to work with someone who's familiar with the normal visual development in a child in order to determine, is the changes in vision because of amblyopia, or is it because of something else going on? Now, kids that with NF1 do have a higher risk of having amblyopia in general than kids that don't have NF1. And so it's constantly monitoring all these things in order to best treat our kids. So I just want to emphasize again that there's no real perfect test, particularly when we're talking about monitoring these optic pathway gliomas. It is, changes in an MRI may not affect vision. Changes in vision may not be reflected on a change in the MRI. And so it's really working together as a team to put together the visual function with the anatomic changes and with other signs of neurologic changes in order to determine whether treatment is needed or treatment should be started or continued. And so I just want to finish by just saying that it's really important that all of our kids with NF1 have constant screening of the eyes throughout their childhood, that you work with an eye doctor who's comfortable seeing kids, who understands the screening guidelines, has the technology needed that is becoming more and more useful in our monitoring of kids with NF1, and most importantly, that can talk with your NF1 doctors, because it's a constant discussion every day about changes and how that may be affecting a child's vision.
Getting set up, I just want to thank Zach for his talk. It's really nice to have. I didn't save your Lish nodule correction. Okay. No, it's really great to have a team of people that are interested in NF and the NF field, and it makes a huge difference in terms of providing good care for our patients, where we really do have a team approach. Zach and I talk or text on a nearly, if not daily basis, at least a weekly basis. In fact, I have someone I need to talk to you about before you leave today. Thanks. Today I'm going to talk, so in the past year, there have been updates in management guidelines. I mentioned this briefly in the first talk. Last year, I talked about the new guidelines that were developed around care of adults with NF1. I will touch briefly on that again today, but mostly I'm going to focus on this new paper that just came out earlier this year, which basically summarizes how we should be approaching care for kids with NF1. Doctors frequently publish these healthcare guidelines for different disorders, different diseases, just to make sure that everyone is doing at least the minimum of what you need to do to provide adequate care for particular populations. So, there are guidelines about managing hypertension. There are guidelines about how you should screen for prostate cancer and things like that. For NF is a very complicated disorder. There are many different features and aspects to NF. And so having a set of guidelines is really helpful to sort of keep people on track. We need to do the eye exam every 6 months in younger kids and every year in older kids. And we need to check for blood pressure at this age and that age. And this is particularly helpful for people who don't take care of people with NF on a regular basis, because they may not even be aware of some of the issues that patients face on a regular basis and may not be aware that they need to check certain things on a regular basis. So papers like this are sort of a blast out to the medical community to say, these are the things that you need to do to take care of patients with NF. So I'm going to go through some of the main points of this paper that just came out, and just in some ways, this is really just going to come out as a sort of a review of many of the symptoms for NF and how we're supposed to follow them. And then at the end, I'll sort of give you a summary slide that tells you sort of how frequently different things are supposed to be followed. So the first thing the paper, one of the first things that it addresses is whether or not genetic testing is helpful. And we've heard a little bit about genetic testing already today. But we don't get genetic testing in everyone with NF1, in part because it's not always covered by insurance, and in part because it doesn't always help us in managing any given individual with NF. If we have a young kid that we are seeing for the first time that has just one feature of NF and we're not sure if they have NF or not, that's a situation we might consider getting genetic testing. And it can help differentiate NF1 from a more mild condition called Legius syndrome, which just presents with cafe au lait spots and freckles in the armpit and the groin area, but doesn't have any of the tumors or other issues associated with NF. It can be helpful when we're not totally sure about the diagnosis. So when there are features that are atypical, and we want to make sure that we're talking about NF. And it's important as we sort of discuss genetic testing with our family members that it doesn't predict what specific symptoms someone's going to have. So knowing the genetic testing results is not going to change that. And a negative genetic test doesn't rule out NF. So if you find the mutation, you know somebody has NF, But the reverse isn't true. If you can't find anything, it doesn't mean somebody doesn't have NF. You can have NF and not find the gene. So I won't talk about this very much since we just heard about it, but just to say that, optic pathway gliomas are quite common in kids with NF. And so I just want to emphasize that screening for optic pathway gliomas in kids is probably one of the most important parts of what we do. And the eye exam, particularly in the early years, is one of the most important things that we can do for our kids with NF. And so doing that regularly is key. We really want to focus on that up until around age 8. Around age 5, the risk of developing an optic pathway glioma starts to go down. And if someone hasn't had one by age 8 or so, it's very unlikely that they will develop one. So the eye exam remains important, but it's really before that we are most persistent about getting it. So we talked about optical coherence tomography, and this is relatively new technology, and it's really becoming more and more important for managing and monitoring optic pathway gliomas. That picture on the bottom right is a child actually doing the procedure. One of the limitations is the fact that you have to be old enough to cooperate with doing that, unless we do it under sedation. But one of the specific areas that they talk about in the paper is brainstem gliomas. So historically, we used to get very concerned about spots in the brain that look like tumors, particularly in the area called the brainstem. This is a brain. The brainstem is this lower part of the brain down here, which contains a lot of important real estate, all of the nerves that go from if you make a thought up here or tell your arm to move, everything has to pass through here. So if you develop a tumor here or some problem here, that can cause a lot of different issues. And even something fairly small can cause a lot of symptoms. In people with NF, we can see very low-grade or benign tumors in this area. In kids without NF, if we see a tumor in this area, we worry a lot about them. In fact, most kids who don't have NF, who develop a tumor in this area, will die of that tumor within 18 months. For kids with NF, when you see a tumor in the same location, they're not going to die of this. And in fact, it's probably going to go away on its own. We have to follow it. We have to watch it. We have to track it. And in some cases, if it enlarges, we have to treat it. But that's the exception rather than the rule. The reason why it's so important to know this is that sometimes kids with NF are told that they have one of these really bad, what are called pontine gliomas, when in fact they don't. They just have NF and they have a lower grade, more benign tumor in that area. So it totally changes how you approach treating those. And when we see these in kids with NF, we generally just follow them with imaging over time. So that brings us to one of the more controversial issues that's discussed in this paper is when do we do scans? Some centers do imaging, do MRIs of all children with NF1 to do basically a screening MRI of the brain to see if there's any evidence of tumors or optic pathway tumors or brain tumors. But the current guidelines and the guidelines expressed in this paper right now are that we do not do baseline imaging on everybody unless there's a specific reason. And that's what we do here. We don't do scans on everybody unless there's a specific reason that we have some level of concern that we think that there might be something going on. So if we see something on our neurologic exam, which is why we see kids regularly to do a physical examination, if there are new seizures, if headaches are progressive or have unusual symptoms associated with them. Headaches are really common, so we don't do scans for everyone with headaches, but headaches with some other symptoms or signs of pressure in the brain. If someone has stroke-like episodes, change in their visual acuity, early puberty or late puberty, or very fast growth or very slow growth, we might do an MRI for those patients. If we have patients that we think may have a neurofibroma in their neck or head, we'll often do an MRI for that. And if we've heard that you can have some cognitive differences in kids with NF. Those cognitive differences don't typically get worse over time. So if you have a child that's developing one way and then all of a sudden starts to get worse, that's another reason that we would do an MRI. And then leg length discrepancy or scoliosis, we would do imaging of the back or the leg, depending on what the issue is. The paper calls to attention that there are several vascular abnormalities associated with NF1. These are less common and less thought about, and that's why it's really important that this paper highlights it, because general practitioners and pediatricians may not be aware. In fact, pediatricians they rarely check children for blood pressure because blood pressure issues are thought to be primarily an issue for adults. But in people with NF1, kids can get hypertension or high blood pressure because they can get narrowing of the arteries that go to their kidney. So this is an arteriogram, and this is a normal kidney. In this kidney, you can see that the artery flowing to that kidney is quite small. And so the kidney doesn't get enough blood, and so the kidney basically tells the rest of the body to turn up the blood pressure so that the blood continues to get to the kidney and keep the kidney alive. But that causes blood pressure to go up in the rest of the body as well, and that's something that has to be treated. It's actually pretty easy to treat, but it's something you don't want to go missed because it can cause permanent kidney damage to leave it alone. Additionally, there are issues that kids can have with blood vessels in their brain. This is basically we're looking top down at a child's brain, and all the white squigglies are arteries with blood flowing through them. And you can see that on the right side of this picture, there's arteries coming out to the surface of the brain. And on the left, there's really not as much flow. And that is the result of something called moya-moya syndrome, which is narrowing of the carotid artery, which is the artery that feeds the brain. And we see this in a small percentage of kids, but it's something that when we're examining kids, we're listening to the arteries in the neck, and we're doing a neurologic exam to see if there's any signs that we need to look for this. And this is also something that you can treat, and so it's something we don't want to ignore. There are a number of different bone and skeletal issues that we can see in people with NF. We heard about some of them this morning from Mr. Rudd. Some of them include large head size, which is important for pediatricians to know because basically most kids with NF, their heads will be a little bit big, and that shouldn't necessarily be cause for alarm, but should be followed closely. A lot of kids with NF tend to be on the short side compared to their siblings or compared to their peers. And again, it's something that we need to follow closely because sometimes we need to intervene either with hormonal therapy or we just track it. And then low vitamin D is almost universal. Almost everybody with NF1 has low vitamin D. And so the paper recommends that we keep that in mind and be fairly sort of proactive in terms of supplementing vitamin D or doing scans to look at bone strength. It also talks about this other sort of unique bone features of NF, which includes sphenoid wing dysplasia, which is an abnormality of the shape of the skull that we see in some patients with NF, the tibial bowing and pseudarthrosis, which we heard about before, and then scoliosis or curvature of the spine, which we see to some extent and maybe as much as half of patients with NF1. We've already heard about some of the ways we screen for developmental issues. Developmental differences are very common in NF. In fact, most people with NF, not everybody, but most will have either attention issues or some degree of learning disability. And it varies a lot from person to person, and there's not sort of a typical pattern of which areas are most affected. So doing neuropsychologic testing, doing evaluations, when problems arise is really key in helping identify sort of what a particular person's learning style is and how best to address teaching an individual. Speech issues are really common, as are auditory processing issues. Executive function and attention issues are very common, and developing a plan through the school is really important. One of the things we're learning more and more about with kids with NF is that there are motor function issues, so low tone, sort of floppy muscles that can impact fine motor coordination. So handwriting may be a particular challenge. So people should be alert to that so that they can recommend occupational therapy if it's needed. And muscle strength may be a little bit low, which can impact participation in sports and other activities. And that can be addressed by engaging with a physical therapist or just engaging in activities that might be helpful, like swimming or yoga or martial arts. The skin neurofibromas and cafe au lait spots are some of the most common features we see in NF. So cafe au lait spots are the brown birthmarks that are usually the first sign of NF1 in kids. It's important to know that they don't predict severity. So if someone has 100 spots, that doesn't mean that they're going to have more severe NF1 than someone who has 6 spots. So the spots themselves don't correlate with anything other than if you have several of them, it's more likely that you have NF1 than someone who doesn't. The skin neurofibromas often start in childhood. We used to say that it starts primarily in adolescence, but we're learning that that really isn't the case, that if we look carefully, they start much younger than that typically and develop slowly over time. And it's very difficult to predict who's going to have just a few of these and who's going to have a lot. Most people have, almost everybody has some by the time they're an adult, but you can't tell in childhood if someone's going to have just a few or very many. They don't become cancerous, but they can be a cosmetic issue, and they often itch as well. Cancers associated with NF. In kids, we see malignant peripheral nerve sheath tumors occasionally. It's more often seen in young adults. Brain tumors, tumors on or near the adrenal glands, which can cause high blood pressure, and leukemia, which is quite rare, but we can see it in association with NF. Really, in kids, the most common type of cancer that we're sort of attending to is the possibility of developing a malignancy within a neurofibroma. And so it's one of the reasons why we follow the plexiform neurofibromas carefully. If it changes in texture or size rapidly or starts to cause a lot of pain, those are all red flags to us that we need to be careful and to probably do some sort of scan to see if it might be cancerous. It's rare that it becomes cancerous, but it's something that we don't want to miss. And we may do MRIs, and we also may do something called the PET scan, which can help differentiate benign tumors from malignant tumors. This slide is hard to read, but this is basically the summary slide at the end of the paper that just sort of gives a time frame for which things need to be done at which point. For those of you who are followed at an NF center here or elsewhere, this is sort of baked into the system, and you will get evaluated for the things that need to get evaluated on a regular basis, and probably maybe even more often than is recommended here. For anyone who's not followed in an NF center but is followed by a general pediatrician or a general child neurologist, this is the kind of information that you might actually want to bring to your doctor so that they have a roadmap for when to do MRI scans or when to do eye exams and how often to do neurologic exams. And this paper is available. If you search it on Google, you can download the entire article for free. All right, and then just briefly, I actually don't know where we are time-wise. 5 minutes? 4 minutes? Way over. No, I know. In general, we're way over. So just briefly, a couple of key points from the adult guidelines, and I brought this up last year, but just everyone should know, and this is relevant to kids too, because as they transition into adult care, breast cancer is at increased risk for women with NF1, and so the current recommendations for screening are to start screening at age 30 instead of age 40 in the general population. So the recommendations are for mammogram at age 30 and then breast MRI. It's sort of a little bit vague exactly what the recommendations are, but we generally try to do breast MRI every other year between age 30 and 50. For adults, it's also very important to monitor for blood pressure issues, again, because of renal artery changes and also because of a growth on the adrenal gland, which can secrete epinephrine and cause blood pressure to go up. And there is an increased risk of stroke in adults with NF1 and also for pregnant women with NF1. It's not a very high risk, but it is somewhat increased. And so particularly for women with NF1, we recommend being followed by a high-risk obstetrician during pregnancy so that they can screen and be aware of those issues. For bone health in adults, this is also an issue, as well as in kids, with osteopenia or osteoporosis being fairly common, low vitamin D being very common. And so here we recommend vitamin D supplementation for everybody with NF1, so that is something to be aware of. But we also will do special screening studies, x-rays called DEXA scans, to measure bone density if someone has any signs or symptoms of osteoporosis. As many of you are aware, pain and headache and neuropathy are common issues in NF. We don't know nearly as much about pain in NF as we should, and it's something that's an active study. But the sort of key things that are mentioned in the paper is that we should be aware that pain is going to be an issue and that we need to sort of ask people about it because sometimes it doesn't come up, and sometimes people don't even realize that their pain is from NF. The other thing is that people should be aware that there's a special type of benign tumor that can occur in the fingertips or the toes called gliomas tumors. So if someone has NF and has severe sharp pain in their fingertips or toes, that's actually something that's quite easy to take care of and can be treated with a sort of an outpatient surgical procedure. We've heard about this a lot already, so I won't talk about this, but just to say that the paper recommends that fertility issues and in vitro fertilization, family planning, all that should be discussed fairly early on. One thing that wasn't discussed earlier that is important to be aware of, there's some unknowns about using hormone supplementation in NF. So oral contraceptives include hormones like estrogen and progesterone. And there's some data to suggest that particularly progesterone may speed up tumor growth. There aren't good studies to show if progesterone affects women with NF in terms of the number of neurofibromas or the rate of tumor growth. But the current recommendation in general is to avoid contraceptives that have very high dose progesterone and try to use ones that use more estrogen than progesterone. And really what that boils down to is the implant form of like Norplant, implantable contraceptives are typically very high progesterone levels. We try to avoid those. And then again, this paper ends with, again, another summary table of all the things that should be sort of done on a regular basis. So with that, I will end, and we can take questions at the end during the final period. All right, thank you very much.
Okay. Well, I can wing it a little bit. Let's see. So what I'm supposed to do is talk about the current and future research in NF1. And I could say, having worked as a child neurologist in this field for over 30 years, taking care of NF1 patients and NF2, and been very frustrated, like many of the patients in this room, with the lack of progress that we've made, because in large measure we didn't understand the molecular biology of this disease. In the last 5 years, we've made stupendous progress. We're not there yet, but we can see signs that there's a lot of hope. And I cannot show you that on in a slide form, but in large measure, this has been related to the discovery of the gene for NF1, and then a discovery of how it functions normally and abnormally in our cells. It's a highly conserved gene. You can find it in animal life. I don't think plants. Thank you, Rachel. No slides? I try to sign in, but you tell me.
Don't worry, I'll help you.
Help
It's
me.
okay. Which ones?
I'm not here.
Oh, you were here. Let me see if I can just
Okay, well, I'm going to continue while she's doing this. And so we now understand what this gene does, normally and abnormally, and don't forget the function may differ partly related to the kind of mutation that a patient may have. It's a huge gene, 56 coding exons at least, and there could be deletions and just point mutations. So there's extreme variability on how it affects biologic processes. What I'm going to show you on the slide, if I ever get it, is that we understand that the way our cells function is through a complex series of steps, starting with stimulation on the surface of cells called receptors, and then through, who knows, 20 or 30 steps ultimately to the nucleus to tell that cell what to do. We have been toying with some interfering drugs in part of this complex pathway, but only until recently have we identified a series of drugs in what we call MEK inhibitors that are capable of turning off a uncontrolled proliferative pathway that an NF mutation confers on that cell. And this is what I plan to talk about in a minute. Can we log into my,
It won't let me. Yes.
can we log into mine? I'm almost done with my talk. I really am. Because I'm going to show you the outcomes. Yes? Yeah, just, so the normal NF1 gene functions as an inhibitory gene. It actually controls among, okay. Excuse me one sec, let me try to get this. All right, wonders. Okay, so now we know that it inhibits, normally functions as an inhibitory gene, and when it doesn't work well, then it's just like your accelerator is stuck on your car. Thank you. So that's the pathway, and can you see how this is called the MAP kinase pathway. Here's the NF gene. It inhibits a protein called RAS, but when it doesn't function normally, RAS is too active. And as a result, it causes unregulated growth, among other things. And here is what we call the interference point for a MEK inhibitor. And we're now going to learn what MEK inhibitors can do for certain kinds of conditions. We're just at the beginning. Now, I am going to talk to you about our early progress in tumors today. But I hope that myself, Dr. Yohei, and whoever else arises to the stage will be talking about MEK inhibitors and another medical management of other NF-related disorders like learning, like bone health, maybe even vascular health. It's the same problem. It's the same mutation as every one of the cells. And this is where the progress is occurring at several arenas, if you will, the NIH, the NF Clinical Trials Consortium. Dr. Yohei showed you a slide on how that's organized. The NF Clinical Trials Consortium is funded by, of all organizations, the Department of Defense, and partly by the Children's Tumor Foundation. And we conduct what we call phase 2 studies. That is to say, after we know the relative safe dose of how to give the medication, we try to find the ideal application of the drug. And now, for the first time, a very large organization called the Children's Oncology Group, which is also funded by the NIH, is going to do a phase 3 trial, which is a randomized trial comparing a standard treatment for optic pathway gliomas with carboplatin vincristine against a MEK inhibitor. And all of us would like to start with a MEK inhibitor. We don't know if it's better. Okay? So we're going to learn. So lots of things are happening. Now, plexiform neurofibromas, I'm not going to go into it, only to tell you it's a complex tumor. It's not a single cell. And if you do MRI scans in adults, 60 to 70% of people will have plexiform neurofibromas, majority of which will never become symptomatic. And we know that they grow most rapidly in early childhood. So if we did a clinical trial, we're probably going to find better response rates in young people. And we're very concerned, and that's why Dr. Yohei and I work so hard to get histories from you and do exams, that any tumor like this that's growing in an NF1 patient or producing pain needs further study, because there is a risk of it becoming more aggressive. Oops. And this is the difference between the two tumors. The neurofibroma on the left has many different cell types in it, and the MEK inhibitor is going to target that Schwann cell, which you see right here. And I'm going to tell you about a different drug that's going to target the mast cell, whereas a schwannoma in an NF2 patient is actually a surgical disease. Can be, because it grows in a relatively confined location and it spares the nerve. So here's a plexiform neurofibroma. It's deforming, and it does cause growth, but she's this young lady does have use of her hand and may be a little uncomfortable. Here's a child with an eye problem. You see a periorbital tumor, and it's deforming. Once again, it's not operable in any straightforward way, and the tumor will eventually grow back, even when it is debulked in part. So this is where and then the last example I wanted to show you, this is a condition where every single nerve root of this young adult, or adolescent actually, 18, has plexiform neurofibromas. And you can see right up here what it's doing to his spinal cord. And he came in with weakness, and he would die from this as becoming quadriplegic had a surgeon not helped him. So these are not surgical diseases really. In the long run, we've had to find medication, and that's what we're doing. So what do we expect from these clinical trials? They're very complex to do, and that's why they're put in the hands of this clinical trials consortium. Highly regulated, involve collaborations between drug companies, funding organizations, and NF centers, and specialists, multiple specialists. But as Dr. Yohei inferred from his talk with the RAINS clinical criteria that are sort of emerging, we want this drug to reduce a tumor in size, improve function, reduce pain, increase strength and quality of life, improve appearance. And we want to give an oral medication. It's a chronic illness, it is. And we want it tolerable, a drug that's tolerable. We want to give it by mouth. It has to be formulated for children and for adults. These are not straightforward requests. Many drug companies don't do this. And also, and I didn't put in, we wanted the response to be durable. Not just while you're getting the drug, but after you stop. So Dr. Wiedemann was the one who basically started this whole momentum at the NIH. And she published an article, her team did, in 2016, which got everybody very excited. The drug was called selumetinib, and it was made by a company named AstraZeneca. It was not approved, FDA approved. You couldn't get it. We still can't get it. But what the industry learned is that NF1 can be a source to get FDA approval for their particular drug. And this company is going to get approval for this drug for one indication, and that's a plexiform neurofibroma. So that's phenomenal progress that we're making as a community. And so, no surprise, every major pharmaceutical company is looking at its portfolio of drugs. coming up with their favorite MEK inhibitor and trying to get the consortium and other NF clinical trials groups to study their drug. Good. And we have to find the most active, safest MEK inhibitor we can, and maybe others. So, you've already seen these, and this is what the NF Clinical Trials Consortium is doing right now. It's studying 2 MEK inhibitors, and that's this Pfizer drug, mirdametinib, and then it's studying another MEK inhibitor called binimetinib, and this is an Array Biopharma product. And then we also just completed a trial in adults with cabozantinib, which is a drug that interferes with mast cell function. Okay, binimetinib is ongoing research in both adults and children, and the Pfizer drug only adults. And this is the paradigm, and I don't mean to bother you too much with details, but you need to understand this. If you were just starting out doing a clinical trial with a new drug for a plexiform neurofibroma, where do you begin? What are the criteria that you can use to judge whether it works or not? And so it was somewhat arbitrary, but in this consortium, we came up with a couple of benchmarks. And they're probably not going to be keepers. But what we said is that at the end of a year, 12 months, the patient had to have at least a 20% reduction in volume of their plexiform to be able to stay on this drug. We probably are wrong, and I'll tell you why, but that's what we did. And when we studied the first drug, this is what we found, that about 42% of the adults had major responses. Well, that's still a miracle, but it was not everybody. We don't know exactly why certain patients benefited and others don't. And then when we looked at cabozantinib, which was the mast cell inhibitor, a very similar outcome, 42%. And you remember, I didn't show you that, but Dr. Wiedemann had showed a 72% response in children. So we didn't come close to that. Maybe because we didn't study children yet. But what we learned from the cabozantinib trial was that in the blue bars, which is the patients who responded, okay, and continued on the drug, we just began to see responses at the end of the first year, and many of them continued to respond during the second year, and even at the termination of the protocol, their tumors were still getting smaller. So we probably did not provide a long enough period of treatment for a number of these patients, and probably those who were taken off the protocol may actually have gotten the responses if we stayed longer with it. So now we're doing cabozantinib in children, and we're doing the binimetinib, which is a study which is drug very closely allied with silumetinib, and we did adults, and which is still going on, and the children have completed their enrollment. I do not have responses for you yet. I am going to predict that it's going to be just as active as the silumetinib. Okay, and this drug is actually already approved for malignant melanoma. So, thank God we have a number of alternatives as physicians and patients in terms of the MEK inhibitors. Where are we going? So the consortium is working on a new protocol which will combine a MEK inhibitor and an anti-mast cell inhibitor. And we got to find a safe way to do this, and hopefully there's going to be synergy where 1 and 1 is going to equal 3. That's our goal, okay? And we got to find a safe way. There's so many things we don't know about this emerging story. The long-term consequences of the drug. How durable are these responses going to be? What are the most responsive patient populations? Is it by age? Is it by whatever unique tumor characteristics? Okay, is it by genetics? So many questions we have. But this hopefully, we're at the beginning, and you can just see the curve going straight up in terms of our knowledge and our ability to help people like this. Now, no surprise, and I'm not going to go into this because I don't have time, but these drugs also work for another indication. It's called an optic pathway glioma. Now, we are allied with another collaborative group called the Children's Hospital of Los Angeles Collaborative MEC 162 group, which is binimetinib. And I just want to show you that they are sponsoring an arm for NF1 patients with progressive optic pathway gliomas. We just started treating patients in April of this year, so the study's ongoing. But I just want to give you a tidbit of how active this drug is going to be for low-grade gliomas, okay? We are a major site in non-NF and NF1 optic pathway gliomas, and I've treated over 12 patients without NF with optic pathway glioma so far with this drug, and the results are almost 100% responsive. And I'm talking dramatic. And here's a patient who without NF, who has a progressive optic pathway glioma, who after 9 months of treatment had a 90% regression of their tumor. And you can see that. And here's a patient with NF1. Caleb, this is your patient. And this is at 8 months. And you can see that the tumor is right here. And this is the response here on one way to look at this, the tumor, and here's another way. So, you know, for CNS low-grade gliomas, it's going to be a lot easier, right? And so the future is now. And I just would like to share my enthusiasm, okay? And then this whole team approach, you can see, it's not a village, it's a nation. It's not a world. And so many moving parts, so many regulatory agencies. But I think NF1 has made its mark here. You've heard that already this morning, and we're off and running. Thank you.